everybody. Today it's a pleasure to have as an invited guest the Director of Stroke at Lenox Hill Hospital and the Director of Stroke Services in the Western region for the Northwell Health System, Dr. Salman Azhar. He's one of our partners at the hospital at the time of managing patients that are suffering from stroke, aneurysms, AVMs, or intracranial hemorrhages, and anything that is related to stroke. This May is Stroke Awareness Month, so it is critical for us to be able to communicate with patients and their family members about how we're dealing with stroke these days during the COVID recovery period. Welcome, Dr. Azhar.
Thank you, Dr. Ortiz. It's my honor and privilege to be part of this discussion. I look forward to it.
Yes, and we were just recently joined by Dr. Serulle and Dr. Langer. And Dr. Serulle appears to be enjoying his lifestyle at the beach.
Yeah, I'm in Miami now, so.
Yeah, remind me how to do that, Dr. Serulle.
David, if you want to join, you're more than welcome to come.
Dr. Langer is flying a butterfly, so I guess that's...
So Salman, obviously during the past several weeks, you have been extremely busy, not doing necessarily what you have been used to your entire career, but you've been in the hospital taking care of patients with COVID. And a question specifically to you is, what has been your experience in terms of stroke during these days? I know that there has been reports of people having decreased numbers of strokes in hospitals, and we have been talking about it week after week here, but also we have seen different presentations of someone with COVID presenting first with neurological symptoms and or stroke before developing any other symptom of COVID-19, and also unusual cases of people that do not have other risk factors for stroke, young people that do not have the common risk factors for stroke presenting with severe large vessel occlusion. What has been your experience?
So that's a great question, Rafael. And I think that, right off the bat, when this pandemic started, especially for the New York City area, where we like sort of the hotspots, one of the hotspots, we saw a real rapid decline in not just strokes, but even people having big heart attacks or strokes. And so people were not coming to the emergency room. And so one of our big fears was what was happening to these people. It now appears, looking at some preliminary data that's coming out of the state of New York, and I'm part of the stroke advisory committee for the state of New York, but also other places, that actually there's also been, unfortunately, a corresponding increase in deaths at home, and maybe deaths due to cardiovascular and cerebrovascular disease. So even though people were afraid of coming into hospitals, unfortunately, that led to more damage to their brains or their hearts, leading to, unfortunately, the untimely demise for them. So we're trying to look at that a little bit more closely. So we've really seen, and this is across the board, if you look at China, if you look at Europe, if you look at the States, everywhere we see this real precipitous decline in stroke numbers in people presenting to the ER. So that's the first thing. And now, as we are sort of coming out of the sort of real heavy COVID pandemic period, meaning that the numbers have started to drop, and we're starting to see stroke patients come back to the emergency room. So if I can just stop at this point and put out a public service announcement, that what's really, really important is, whether we're in a crisis time or not, it is so important for people to realize that we at Lenox Hill, for example, have an area, an emergency room just for COVID patients, and another part of the emergency room which is for non-COVID patients. So you don't have to be worried to come in. In fact, you need to be worried if you're trying to stay away from the hospital, because you're going to end up with more injury and more damage. So if people are having signs and symptoms of a stroke, face, arm, speech, anything like that, call 911 and get yourself into the hospital, because we know we can do so much more for you now. And don't be scared about coming to the hospital, because we really have the ability to protect you from getting COVID in the hospital. It's really much more important for you to get taken care of in that stroke, for that stroke. And time is of the essence there, really important. Now, COVID stroke is different from regular stroke. Yes, one, we've seen some large strokes happen in young people without risk factors. But also we've seen many, many more patients across our system and across New York State have strokes once they get into the hospitals. They come into the hospital with COVID, they've got breathing difficulties, they may get put on a ventilator, and then they're having their strokes. So we see a high incidence of strokes in patients with COVID. Oftentimes after they come into the hospital because they're on a ventilator, but even before. And we kind of have started understanding what is causing that. We know that the inflammation from this virus, which is such a novel virus, I've never seen anything like it. And you and I are not that young anymore, so we know we've seen a lot of things happen. This virus is really toxic to the blood vessel and toxic to the blood. So it causes a tremendous amount of clotting, both in the veins of the body, but also in the arteries that lead to the brain. And we're seeing strokes, we think, because of the high level of inflammation and this toxic effect on the blood vessel wall, which leads to much more damage and therefore many more clots. So you could be 22, have COVID, not really have a bad case of it in terms of breathing, but for some reason your blood vessel responds poorly to it and you can end up with a big stroke. So again, it's important to know the signs and symptoms of stroke, and no matter whether you're having a stroke and you have COVID or a stroke and you don't have COVID, you got to get yourself into the hospital.
Yes, and like you said, right now we're past that critical period where the hospital was really packed with patients that were suffering from COVID. We're far away from those days, to the point that, for example, in Westchester and Phelps and Northern Westchester hospitals, we're already performing elective surgeries and bringing people that do not need only emergency or urgent procedures. Likewise in the entire Long Island region. In New York City, we're still following the guidelines of the government, and still we're performing only emergencies or urgent procedures, and obviously stroke is an emergency, or any mini stroke, TIA, any stroke-like symptom. Dr. Serulle, you have seen a lot of these in Phelps as well. I know you have had experience with the very young patients suffering from very unusual large vessel occlusions. Any comments on that?
Yeah, we had a recent 35-year-old lady who presented with a large vessel occlusion, very high D-dimers, but otherwise, she's been negative for COVID. We've tested her twice. We've tested her antibodies. Interestingly, about 2 months ago, or back in February, she did have what the husband describes as a very, very severe flu, for which she stayed home for like a whole week. That was right at the beginning, or right before the epidemic hit the city. So I think it's possible she may have had, COVID, and then we're testing antibodies, and then the antibodies are negative. I'm not entirely sure how accurate, the antibody testing is. That's one thing. So, these patients, I've seen them in the literature. There's a few cases already published, young patients, hypercoagulable, developing, large vessel occlusions, which happen to be COVID positive. This case may not be COVID. I don't know what has been the experience here of everyone with the antibody testing, but it seems that it's not entirely, accurate probably.
David, you have been very up to date with the literature and the experience with testing. Any comments on that, on the fact that many people are getting negative tests, even twice or 3 times being tested, and then they test positive a 3rd or 4th time, and likewise people that were sick, and then the antibody testing is negative. Any scientific reasoning for that?
No, I just think the tests aren't all that great. I mean, they're just, the PCR test is, the first set of testing. The saliva test is very sensitive, but less specific. The PCR test is really specific, but less sensitive. The PCR test is 80% sensitive, means 20% false negative rate, which is too high if you think about it. I mean, if it's 20% of people who have COVID, you can't. So what we're doing is we're treating based on clinical presentation. We're saying, if it looks like COVID, I had a patient came in, was COVID negative on admission, had infiltrated chest x-ray, low platelets, thrombocytopenia, fever, and somehow broke through the ER. Was, we have to have better screening, because in general, if somebody presents with COVID clinical symptoms, they're COVID until proven otherwise. I think that's why we got to treat everybody in the hospital like they're COVID. As far as the antibody testing, it's a harder one to understand. I think, maybe different people have different immune reactions, some more robust. You have to wait till you get an IgG reaction, at least 2 weeks after your infection. But these tests they're suboptimal. It's really throwing a whole level of, a problem into the ability to know what the right thing to do is. I think in the end, if you had COVID and you recovered, you're probably okay. I mean, there's no reason to think you wouldn't be, at least for the foreseeable future. Every other viral infection known to man has some degree of humoral immunity after an infection. How long it lasts, we don't know. But if you've had the virus, you're probably not going to be able to get it again. There'll probably scatter reports of people getting it again, but did they really have it to begin with? Maybe they had something else, who knows? As far as if you didn't have the virus and you think antibody testing is going to prove something, I would be circumspect. I mean, if you didn't have a clinical symptom, don't be surprised if your antibody testing is negative, it's because you've had exposure. And if your antibody test is positive, I'm not sure if I would just bank on that as being, maybe maybe you're protected. I just don't know. What's super interesting though is that the amount of COVID positive people in New York City, that the antibody testing is up to over 20% for New York City, around 20% for New York State. The Northwell employees are around 13%, which is, I think, super interesting. Yeah. So I think the antibody testing probably has some value in just, surveillance to see, kind of like when you're talking about reopening society and, what the penetration of I think it's valuable from a macro view, because the errors in the numbers, the more people that get tested, it's really valuable to understand the population of what the immunity might be. But on an individual basis, maybe a little less relevance than there might otherwise be.
And Salman, apart from the emergency room, what measures is the Department of Neurology at Lenox Hill taking in order to, number one, take care of patients, and number two, prevent that there's any contamination either from healthcare professionals to patients, or patients to patients, or patients to healthcare professionals?
Right, so that's a great question, because I think, as we discussed earlier before this started, that the reopening process, whether it's for healthcare, for anything, is really much harder than the closing down process. When everything closed down, it was like an axe falling down and we sort of shut everything down. Now we're reopening. Now, I think that one of the silver linings of this crisis, and they're few and far between, is really the penetration and the prevalence of telehealth, video consults, teleneurology, and we are doing a lot of it. And we're able to do actually really good, I think, teleneurology in the system, as you guys are also, and teleneurosurgery, and really take care of our patients remotely. So what does that mean? How does that look? So number one,
look at Yafell. He's in Miami.
I know Yafell is. Although he and I were involved in a case together, so I don't know how his catheter got to the patient so far. But
I just fly. I fly back and forth.
Yeah, clearly, your own jet. Yeah, is it COVID free? That's the question. So the thing is that, I think that, look, listen, we assume every patient is COVID positive, to be honest with you, right? So number one, we try and minimize the density of patients by doing a lot of teleneurology and video consults. And we've been really good at that. And we've really been able to really deliver care to new patients and follow-up patients. Number two, patients who are coming in, we've got distancing in our waiting room. So some patients do have to come in for particular tests, and we have special social distancing. Now those are far and few between, because we really haven't fully opened back up yet, right? but we do employ social distancing. We have very few actual appointments happening in patients, since most of our appointments are going to be virtual from now on, until at least we get to a point, and this is where David's point is very important. Listen, we have to be able to rely on these tests, right? And there's one thing, the tests are only as good as perhaps the last few days that you were exposed, because that's the PCR test. And then the antibody test is only as good as 2 weeks ago. It's not as, it doesn't tell you what happened in the last week or the last 2 weeks. So knowing that, we've got to assume everybody is positive, and we've got to protect our own staff and ourselves, but we've also got to protect patients. And the way we do that is by doing much more teleneurology, much more video neurology, and also by really having very strong social distancing, even in our waiting rooms. We only have very few patients coming in. We only use a few exam rooms. Each exam room is thoroughly cleaned between patients. If we have to do testing, like with equipment like EEGs, we clean everything very thoroughly. So we're extra careful not to spread this infection anywhere else. Can I just say one thing, which I think is there's this interesting thing that came out of South Korea. Now we heard about it in an aircraft carrier. It's about these people who were infected, clearly had the infection, then they were negative, now they're positive again. And you guys may have heard about that and maybe even talked about it in one of your previous sessions. We think a lot of that coming out of the South Korea experiment, and David, you can comment on this probably, is from dead virus remnants. So some people don't just clear the virus, there's actually dead virus. You're no longer infectious, but you have dead virus floating around in your nose, in your pharynx, and so in your secretions. And so when you get tested, that dead virus, the RNA from that dead virus shows up. So that's another wrinkle. So you're not infectious, but you have a positive COVID test. This is why this is such a complex disease to take care of, especially when it comes to protecting each other, all of us, from infection.
I mean, about 2 weeks ago, I brought a patient who's COVID negative, converted while he was in the hospital. I admittedly, I didn't put full PPE on. I've known him for 8 years. I think I might have, shaken his hand or touched him. About 5 days after he got admitted, last Wednesday, I got a high fever and a myalgia, and went to the ER and got tested, was negative. I had nasal swab, was negative. I basically took 80 milligrams of Pepsid, 4 times, those 3 times I took 240 milligrams of Pepsid for 48 hours. And my fever, the first night I rigered, the next day I felt okay. Like I felt like a little wiped out, like tired, but no more fever. I hadn't had a fever since last Wednesday. And my test was negative. And by Sunday, I'm absolutely fine. I have 0 symptoms. So I spoke to one of our, Linda Kirschenbaum, one of our intensivists, and said, what do I do? I'm not going to sit at home like this. And she said, actually, if you have no fever for 4 days, you're not infectious. And that even if you had the virus, you don't get I said, should I repeat the nasal swab? She goes, no, because of this dead virus issue, that the test at that point is irrelevant. You have to, in order to spread the virus, you have to have some symptoms or a fever. And so that's why this whole thing with the asymptomatic carrier, what is that? Is that a dead virus? Is it really, something that's to be really concerned about? The other thing that's come up with about children, can children be vectors? I brought this up before, but in Vaux, which is a small town in the Veneto, they did surveillance testing with antibodies. They did COVID testing for the virus the day of the first death, and then 2 weeks later after social distancing. And it was about a 2.5% COVID positivity in the population at day 1 and 1.6% at 2 weeks later. So, social distancing seems to work. We all know that. And the key is to keep that R naught low. But that's the point, that I think that you have to look at testing as a public health issue. It's really, if you take it too personally, you have to use it as part of the big picture. But it seems like the testing either isn't good enough, or the virus is kind of wily, or a combination of the two. And so you have to be smart, can't be too smart about it. And you have to take each case individually and not expose yourself, but at the same time, look at the global picture of public health to know, like you said, I completely agree. Coming back on is a lot harder than turning off. And that's what we're going through now. That's what makes it so difficult.
And I just like it, David. The thing that really struck me, and you had mentioned that Northwell employees, so these are healthcare professionals taking care of the sickest of the sick patients, and doing a really amazing job. We all wore the PPEs, right? And it's not like we wore spacesuits for the most part. We wore what we had to wear, right? We wore a gown, we wore face shields, we wore the N95 and a surgical mask. Very few of us got infected.
Yeah.
And so social distancing works, PPEs work. And why is that important to the average person or the regular person on the streets? Well, you come into a hospital, we're not carrying infection from one patient to another. Okay, that's really, really crucial for people to hear, because we first of all, to do that, we would ourselves have to often increase our risk of infection. But the gowns and everything that we dispose of right after we see that patient, they work, and we're really very careful about making sure that there's no potential for, or very low potential for, cross transmission. So that is really important for people to feel comfortable to come back into the hospitals.
I think one of the things I read was that, I think it was in New York, that the risk factors of transmission were a family member with the virus, using public transportation, and restaurants, before they closed. That those are the three biggest. It's social. It's you're too close to people for too long. You're either with your family or in a restaurant, at too close proximity, and public transportation is a no-brainer. But I agree with you. It's amazing the hospital infection rates were as low as they are. I mean, in our department, I think we had total, maybe had 50 people. I think we had 5 total.
Yeah.
That were proven positive. And one of the guys, one of the nurses, works at Wyckoff, also. So we don't know, where he picked it up, but that's pretty amazing. And
Yeah.
It argues that either PP works, the virus just doesn't jump as quickly as you'd think. And the hospital's a remarkably difficult place to constantly be that aware. I mean, you go to the bathroom, you touch a doorknob, it's just, it seems like I was watching myself at the beginning of this, of how many times I went to buy a Starbucks coffee, and I pull my wallet, and then I give the card, and then she gives the card, and oh my God, you touched the coffee, and it's impossible. So, I think it's super interesting for sure. And I must say, I was going to say at the beginning, I mean, you're, to go into your value, what you've offered. I think you've seen, as a neurologist, and when we saw something and moved on, I think I know how important your role was. Obviously, with the case that came very close to home in our department, and I think the world of what you're doing and what
Thank you
for us and for our team, and also knowing that the neurological aspects of this weren't the things that people were all attracted to, and yet we had a very robust and talented group of neurologists who, really made the effort under duress and in environments that you weren't used to being in.
Yeah.
And so it didn't go without notice, and we really appreciate that.
Thank you. And I have to say that, the feeling is mutual. It's really been a really strong team relationship between us and neurosurgery and taking care of these patients. Yafell and I have had patients together very recently who've been COVID positive and had big clots and stuff like that. So it's about just diving in, right? You got to take care of the patient. You got to do the smart things to take care of yourself. It's really about but you think, and I think this is key. It's really important for us, and we have done this successfully. All of us here, in our first goal has always been serve the patient. Be careful, but serve the patient. And I think I'm very proud of Lenox Hill in particular, but Northwell as a whole, as really having done a tremendous job across the board. You and us, the intensivists, the hospitalists, all of the people, tremendous, nurses, everybody. So it's been a special privilege to be here during this crisis.
Yeah, I'd say, as bad as it was, I think it's an experience that will hopefully last a lifetime. I hope we carry on going forward and draws us closer,
Yep. One thing I think, and Rafael, I think coming back to stroke on this, which is that, the sad part of this virus is many sad parts, but one of the real things that all of us have seen is that it doesn't affect people equally, right? So we just heard from the antibody prevalence data that it's affecting minority communities and and at-risk communities to a much higher level. There's much more prevalence of antibodies in our poorer neighborhoods, right? And that's going to, and we see that in our stroke population. There's a higher risk of stroke in our people who are racial, of different ethnicities, different races, but certainly of also different socioeconomics. And that may be because if you live in a multifamily home, this virus can race through that home. But it may also be how this virus perhaps targets, there are genetic differences in how you react to this virus. So we've seen more strokes in our African-American neighbors and in our Hispanic-American neighbors, and certainly perhaps even to some degree in our Asian neighbors. So there's definitely, unfortunately, it hits people who can least afford to get hit. Nobody can afford to get, but it really has been, unfortunately, a very unequal and impactful virus when it comes to certain communities. And that's tough to see, but it also means that we've got to do a better job of getting out there and preventing this virus from resurging.
It's almost like the tornadoes and hurricanes always hit the trailer parks.
Yeah.
It's just so sad. I do think though that, it's not related to population density either. There was a study that looked at zip codes in New York City of where the highest rates of infection were. And they were all in, the more the poorer areas. Now, is that because people took off out of New York? That might have been possible. I think it has to do with they were essential workers. They had to use public transportation. They couldn't work from home. They were functions of their socioeconomic background, but not related to the fact that they didn't have money. It had to do with their behavior because of the environment they were in. And that's a complete different, reason. I mean, we always think when the poor, and particularly the African-American community, their access to care is less, their infant mortality is less, their rates of cancer outcome are worse, diabetes treatment is worse, heart disease is worse, everything down the road. And we tend to always think about it as access to care. But for this, I'm not sure if that's what the problem was. I think it had more to do with who gets infected and why. And it's almost like the reason why these people are getting infected is because they were just exposed. And they couldn't do the things that wealthier people do to avoid getting infected as easily. I mean, it's maddening. It's just so sad, and so, I think it revealed so much about American culture. And now that it's become politicized, where you have, angry white people running around, with freaking guns. I mean, it couldn't be a worse example of, such a politicized medical problem. We have our president taking chloroquine, for Christ's sake. I mean, it's just mind-boggling. But, I think it's all up to us. I mean, we talked about this at the beginning in our department. It's up to us to educate ourselves, not because we're necessarily going to be taking care of patients. Because I'm not an intensivist. I know dick all about pulmonary medicine. But the point
I'm glad that you can say that on Zoom, because that's
But the point is, we have to be leaders in our own homes and our communities. And when we do get access to press or media, to speak from a lay medical perspective about the importance of these things and our own vision about why this is impactful to us. And we're going to get that opportunity. I know, about with our upcoming Netflix show, we are going to get a lot of attention.
Right.
And we're educating ourselves. When this opportunity comes, we're going to take advantage of it. And, like I said, I unfortunately have to get off because I have a meeting that I couldn't move, but I'm grateful for our relationship. I'm grateful for the opportunity to have had this experience for the last couple of months and to lead a group of just wonderful, wonderful people, and to innovate and to change and to embrace chaos for the common good. Mm-hmm. We have a long way to go, but this is a springboard to a different world, and we have to be the ones to push for it. And this meeting itself is an example of that. So I just want to congratulate you and certainly Raf and Yafell for continuing these things. And please join us again. We'd love to have you as again and again. We do this every Wednesday. We can bring other neurologists on as well. I think it'll serve all of us well if we use this opportunity, even if it's a socialization. Just sit down for an hour and just, because we can't do it face-to-face anymore. We might as well do it here.
Well, not especially after you just got infected. No, please stay away from me. And that butterfly, I was mesmerized by it while you were talking. So yes, absolutely. There you go. Listen, my friend, stay safe, stay well. It's good to talk to you.
Bye, Dave. Thank you. So Salman, well, one important topic that we should discuss is stroke management during these days, and specifically separating preventive, primary prevention of stroke, acute management of stroke in the hospital, and secondary stroke prevention. Are we making any changes in the general population, number one, and in specifically in people that we know are either COVID positive and or have abnormality in their labs that would suggest that they are COVID positive?
So great question. Don't have all the answers, number one. We certainly have. I'm going to give you a couple, one simple anecdote. So we've seen this a couple of times now, more than a couple of times. Someone has COVID, brings in here, whether they get intubated or not, fine. They get discharged, and something called their D-dimer, which is a measure of inflammation, but it can also be a measure of clotting, is elevated. They go home, and a few days later, they're coming back in with a stroke. So there's no question that patients who have persistent elevation in these clotting factors, and it's not just the D-dimer, we're seeing people who never had a stroke before have elevation in antibodies that are antibodies that would make you clot. Probably all from the viruses causing damage to the blood vessel, right? And the level of inflammation. So in those patients that we have seen this increase in inflammation, increase in antibodies, we are putting them on stronger medications like Eliquis and Xarelto. These are the new anticoagulants for a short period of time to help them ride through this period so that they don't end up with a stroke. And the population where that seems to be really important. So in the past, people have had a stroke. Most of the patients who come in with a stroke and get discharged get put on aspirin or Plavix. That's kind of standard. Here in the COVID population, oftentimes they're putting these patients on Eliquis or Xarelto, even though they don't have things like atrial fibrillation, which is a common reason for using these blood thinners. And the reason is, again, because we know that these people with COVID are much more likely to clot, even going out. Now, we don't know how long that's lasting for, since we don't have follow-up data, but we're looking at all these patients via video consults through our stroke clinic and our stroke service as an outpatient, and then remeasuring their inflammatory markers at 1 month. And if they've come back down to normal, taking them off the medication and putting them just on an aspirin. So that's different. That's a big, big difference. Same thing with someone who comes in and has a clot somewhere else, like in their vein or in their lungs. We are putting them on blood thinners and then obviously watching for their risk of stroke. Let me give you a common sense thing. Somebody called me the other day and said, I just tested positive for COVID. I'm afraid, young person, friend of mine, I'm afraid that I'm going to have a stroke because I've read this thing about the studies that came out. What should I do differently? As a physician, and there's no data because we don't have a large enough study to look at this, I'm telling people, my patients, if you've just tested positive, go on an aspirin, okay? Not more than that, just a baby aspirin, because we know that has some benefit. Is that the right thing to do? I don't know. But certainly, the science would indicate that that might be the right thing to do, and it's probably not going to hurt you. So it's probably not a bad thing to just go on an aspirin to ride through that COVID storm, that COVID period when you have a lot of inflammation.
Should people also take it even if they're not COVID positive in these days, given that a lot of people don't know if they have been exposed or not to the virus?
I think you have to look at your risk, right? I mean, suppose you're someone who has a lot of stomach reflux, esophageal reflux. You're sitting at home. This is a high stress time. Every night you go home, every night you go to bed with a lot of acidity in your stomach. I wouldn't take an aspirin because obviously you may be higher risk to have more complications from that. You've had a bleeding problem in your eye. I wouldn't automatically go on aspirin because you may have more bleeding issues for no reason.
Okay.
You're, on the other hand, you have no risk factors. You're a young person. You're not in any other risk. Does an aspirin a day for a short period of time, maybe a month or so, hurt you? Probably not. So it's not just, I really don't want people just taking an aspirin without considering what other complications may happen from aspirin. We know that aspirin has complications.
And then other question.
Salman, I have a question.
Yeah.
Aside, you talk about markers and you talk about labs, and I know you mentioned D-dimers. Any other markers you think are kind of important? I mean, D-dimers obviously is non-specific, but are you following other markers in these patients like CRP, ferritin, or anything in particular, or any combination of markers that would suggest, okay, this patient may be hypercoagulable because of COVID?
No, so I think that, D-dimer, CRP, and ferritin are all inflammatory markers.
Right.
We test them frequently, not even when patients coming with a stroke, they're being tested frequently because there's signs of inflammation. And this virus causes a tremendous amount of inflammation. So nothing to do with stroke, right? So now in a subset of that group, the D-dimer can rise even very high. And in a subset of that group, it may not just be pure inflammation, it may actually be a clot.
Gotcha.
And we know that before COVID ever got here, if you had a very high D-dimer, it was either because you had infection, you had cancer, or you had a clot sitting somewhere in your legs or in your lungs, right? Those are the three big things. That hasn't changed, right? So we know that. So I'm not trying to say that following this will tell us exactly. We know that if all of a sudden your D-dimer starts to rise, we've got to look for clots, right? And then that's the case where we got to think more of it.
Right.
Beyond that, we know that we see patients who have had COVID, and this is again a virus that affects blood vessels, who also have things like anticardiolipin, beta-2 glycoprotein antibodies, and lupus anticoagulant antibodies. All of these antibodies are antibodies before COVID, existed before COVID, but only in a small number of people, and they typically cause those patients to have clots. Now we're seeing these in COVID, we're seeing an uptick in these antibodies. Is that significant? We don't know. But certainly if we see an uptick in that antibody and the patient's had a stroke or even anything suggestive of that, we are treating these patients much more aggressively than we would normally do. So there are signals, right? You look at signals, okay, that suggest that that confirm this is a very inflammatory, a disease that affects the blood vessel. So we have to take those signals seriously. And quite frankly, I think we've done a lot of the initial legwork in New York City, and certainly at Northwell and at Lenox, to try and understand how to manage these patients better. I mean, what do you think? What are your thoughts on this? I mean, you've been taking care of these patients like we have also. How do you guys approach these patients?
Yeah, I mean, I think that it's, as you mentioned before, our own experience, and I think it's not only our experience, I think it's probably the consensus in the whole country. Large vessel occlusions have, for the most part, decreased during COVID. That's been our experience at Lenox, our experience here in Westchester as well. There was a paper, I'm not sure if you're familiar with that paper that came out, I think last week, where they actually partnered with Rapid, the company, and they looked at all the rapid scans in the country, which I think is a pretty accurate way to kind of like look generally at how much stroke evaluations we're doing. And basically they saw from right before the pandemic to the peak of the pandemic, a few weeks later, a decrease of about 50% almost in rapid scans across the country. So whether there are, I don't think there are less strokes with COVID. It's just probably a mix of either patients staying home, one thing, but also a lot of patients hospitalized because of COVID, which are being underdiagnosed, maybe. These patients are probably very severely ill, and their neurological exam may be changing, but probably, we're not paying, or not because we're not paying attention, but just they're very sick. So probably because of that combination. So that's from the large vessel occlusion perspective. But that's why I wanted to get your perspective in the more, in all the other strokes that we generally do not see, that you see, the smaller vessels, the venous thrombosis that I'm sure have occurred, and that, probably occur as equally, as often in these hypercoagulable states,
Yeah, I think it's, I think that, you're right. We saw a bit, I did look at that study. We saw a big drop in the number of acute strokes, so stroke codes using rapid to diagnose stroke code, right? There's a couple of things, but we've also seen an increase in death rates.
Right.
So the real question here is not just that, is that I think the question is what happened to those strokes? Large vessel strokes, if you don't take care of them, oftentimes have a higher risk of mortality, right?
Right.
So are we seeing people die at home, unfortunately, which would really be perhaps the untold story of this virus is that, yes, people have died in hospitals, but how many poor people have died at home, right? And we don't know that yet. And I'm not saying it's
and by the way, the mortality rate of LVOs in the older population, which are probably the ones that are mostly staying at home, is actually very high. Those patients, older than 80, mortality rate of untreated LVO approaches probably 30, even 40% in some studies.
Right.
It's a pretty high mortality.
Yeah. So we have, I'll give you another anecdotal case. We've had a case very recently where the person lived alone, was elderly, and was found to have a stroke that's probably about 4 days old.
Right.
Right now, when you don't have any social interactions, when you're not going out to the shops, when you're not doing stuff, guess what? 48 hours can go by and nobody's checked on you.
Right.
And unfortunately, that can happen also, right? So it's higher death rates. It's people not getting checked on. It's but maybe there's something else there. Maybe I think the take home from all of this is if you notice you're having something going for, please come into the hospital. We can take care of you. You don't need to be scared. That's so important to get out there. Now, for the small vessel strokes, there's no question that you're absolutely right that they may not be diagnosed as frequently because people come in short of breath from COVID.
Right.
Right. But remember, our COVID prevalence in New York City is what? A little bit more than 20%. What happened to the other 80%? They didn't have COVID. And those are the same people who typically make up our stroke patients. So the third thing for us at a place like Lenox is people have left our neighborhoods, right?
True.
I think I saw this thing in the New York Times of 40% of, I think it was 40% of the Upper East Side neighborhood that surrounds Lenox and other places has gone away, right?
Right.
So I think all of those factors that it's going to be an interesting thing, not because we want to look back, which is important, but what do we do when a second wave comes through? How do we do things differently so we don't lose those people dying at home? That's to me the biggest challenge for us. I mean, I don't want to go through all of this now, then do things exactly the same way. But if God forbid a second wave comes through and not have learned our lessons about how to take care of patients, COVID or non-COVID, during these crises. That's the question I think that we have to sort of ponder. I don't have all the data. We don't have all the data, but we really have to think about how to do this differently in some form or fashion.
Another question, Salman, is rehabilitation. After stroke, most people do require either inpatient rehabilitation, outpatient rehabilitation, and there are some limitations now after COVID. Number one, given what's happening in nursing homes and the very sad data that is coming out of nursing homes, is it safe for patients to go to rehab centers after being discharged from the hospital? That's one question that a lot of people would like to get your take on. And two, how can people recover at home? What can they do in order to be as active as possible given all the restrictions?
So, right, there are three places typically people go for rehabilitation: home, nursing home, and acute rehab facilities, right? Number one, the number of acute rehab facilities that are open for admissions for acute stroke has dropped dramatically in New York City. So we've even lost that top tier of rehab, which is like a 2-week rehab. So there's still a couple open. Two, and one of ours, Glen Cove in Long Island, is definitely open. Two, you're right, nursing homes. Even if I wanted to send a patient to a nursing home, a lot of family would say no to me because they've heard the same stories you're absolutely right talking about. I think that just like anything else, with the governor's new guidelines for nursing homes where everybody has to be checked twice a week, They've got to really establish, much higher levels of PPE standards. And I think nursing homes will get to a point of being safer. Listen, to be honest with you, I think if I had a loved one who had a stroke right now, I could find a way to take care of them at home, I probably would, right? Because nursing homes, no question, not because it's not their fault. It's just the environment. It's a facility with people at risk who are on top of each other. I mean, that's just the nature of it, right? And so I think it's not the nursing homes that are at fault per se. It's that this is just the kind of place the virus likes. So right now, we are starting to see nursing homes stabilize. We are starting to see that being another option now, whereas perhaps a few weeks ago, it was very hard to get a patient into a nursing home and feel safe about it. But number two, very hard to convince the family, rightfully so, that it was safe. I think the real question is the third option, which is again where this is the silver lining in this crisis. We have, Northwell has an app called Exercise RX. We've partnered with this Irish company called Solaso. And so to try and actually send people home, and we have the ability to actually design specific neurological rehab programs for that person. And they can, it gets sent to their laptop or their computer or to the iPad. And if they have a family member at home, they can work with that so that they don't have to go out to or have someone come in, do therapy at home. So there are options there, which I think are really starting to be explored by our system. I've definitely used it. It's really been, I think it has been helpful for the right patient. So that's where technology can make a difference. I think you have an app which basically, playback, which allows people to really understand their disease state, really communicate with the therapeutic team, and also be able to sort of.
Now it has telemedicine integrated.
Telemedicine integrated, so we're able to sort of, exactly. So you're able to look at these people actually doing rehab at home.
Yep.
If you were able to give them an exercise. So Exercise RX is a Northwell program that is an app-based program that we're able to design a specific set of exercises for people going home with stroke or any other impairment. Playback is a great app because it allows people to really connect. You can see them, you can actually visualize them doing these exercises. You can correct them, but more also, it gives people a lot more information about what happened in the hospital. So I think that technology, if there's ever a silver lining, it's the technology that we could not use, quite frankly, because there were a lot of roadblocks. Those roadblocks have been removed, and now we can really use this technology even after the COVID crisis.
Yeah. Any other comments, because we're running out of time?
Oh, I think this has been great. I mean, listen, I've long lived for David to say a couple of swear words on camera. So we have seen that, and I appreciate that. No, listen, I really appreciate what you guys have done, and really sort of getting the message out there. I know you've been at this for many weeks now, and I appreciate that really it's important to communicate to everybody what we're doing here, but how also in general these topics are tough topics to understand, especially with a new virus. So I appreciate all of that you're doing.
Well, thank you for your very nice words and your teachings, because I'm sure a lot of people are going to benefit from this. And thank you, Yafell.
Yeah, thank you guys. Thank you, Salman, for coming over. It's great having you.
Next time, show me how to be in Miami.
Okay.
Just come. We'll do it from here in Miami next time then, yeah.
Thank you, guys.
Take care.
See you.
Thank you for it. Bye-bye. See you. Thanks, Rafael. Thank you.
Bye.